Stable, EF has come down from 50 to around 35 to 40. But 1 month after the patient presented with chest pain and shortness of breath.
That's problem with covered stents.
GraphMaster did the trick.
So we again took the patient to CathLab and did the balloon and put another stent distal to the GraphMaster and also
Fix the circ.
did PCI to the circ. This was the final angiogram. The lady is still alive, almost 1.5 years.
I think you are a great save, and must say you are very, very lucky that you are able to wire and do all this. Excellent save.
So this was the final message. Hard work pays, fight till last, believe in teamwork, perseverance, do CPR, but it was not required in this case. Finally, miracles do happen, and have faith in the God.
Good
That's
save.
perfect.
Good save.
Yes,
Thank you.
Perfectly right, but can we have the very first view of the LED? Can you have the first view of LED, please? So you see, when you have this kind of an LED, you already know that this is basically, if you look carefully, that the distal LED, the distal LED fills from a very small collateral which is over there. So your desire actually is to get into that very point. Now, it is always the most tricky part is to place your wire at the right place over there. So anyone has the concept of bringing a wire in over a balloon, inflating the balloon so that the wire stays central. Anyone with that concept?
Inflate the balloon you're talking?
You have a balloon, bring it as near as possible, then you inflate, and it's a big balloon now, because over here it's a big balloon, right? So you need to make it central. So you have a balloon which is about 2.5 or something like that, keep it there, and then it may be your over-the-wire balloon or something like that, keep it there.
This is what the microcatheter will do, and you are making your balloon a microcatheter basically.
No, basically you see when you're doing this is over-the-wire balloon.
The same thing as
But the microcatheter, the difference is that the microcatheter may float in one direction. But if the inflated balloon will usually tend to stick to one place. This trick, of course, only works when you are sure that the lesion is centrally placed. But if the lesion is not centrally placed, then you never...
Yeah, but sometimes it could be very difficult to say, first of all, it's centrally placed or not. Then also the balloon, I know you'll have to use like, 1:1 303.25 balloon was centrally, or that the likelihood of causing a dissection to me would be more if I go that close to the lesion, and if I am not in the right place, then it's going to go under the plaque more likely than anything else.
Another thing is about our problem is that many times we're faced with the economics of the whole thing going on. So how many of you would consider going in with not the workhorse, but something which you feel will actually cross as your first wire?
Actually, when we are using a wire, we should know what is the quality of this wire. Like for the Pilot 50 is a hydrophilic wire. It's not a CTO wire. It will slip into any micro channel. It will slip into the micro channel, and it's very prone for dissections again. In this case, workhorse wires is always advisable, because it will give you an idea what sort of the lesion is, what is the reboundness of the wire, and what wire to be used next. After that, it should not be in hydrophilic wire when there is occlusion, total occlusion after that.
Hassan Suhail, he is presenting the case.
Right. Thank you. I think we have our next presenter with us.
Thank you.
Thank you, sir.
Great save and good case.
And after that, we have, I understand, a presenter from Punjab Institute of Cardiology also. Is he here? Yeah, he is here.
Yeah, let's see.
After this one.
We have time. So Hassan Suhail is our international fellow from Tabard Institute, and this is
It's
My
10 minutes
case-
for you and 10 minutes later on for PIC bank.
I think we keep talking about JS, KBT and all that, keeping the balloon in the diagonal for main
See,
vessel. So this is the disaster from that. So I'll show you it's never
This
not
reminds me
always
of
safe.
this reminds me of a case that I was doing way back many years ago, and I ended up with a false lumen entry. In fact, I presented this case later on in Pakistan live or in one of these our meetings, and I had a sure shot dissection going into the wrong place. But the second vessel was also carried out first, and then this was done.
Ready?
The patient afterwards became totally comfortable.
The loading presentation.
And we told him that you have to come back after 6 weeks, and we thought that this is going to be an investment procedure, and we'll come back and do it. The gentleman did not turn up, and then after 2 years, he suddenly came into my outpatient again. And this time he was again having symptoms. So I said, why did you come earlier? So he said nothing was doing. But anyway, so I knew what my plans were, and now I was quite sure that the system was healed over there. So, but hold and behold, start again the same damn thing. Because why I'm pointing this out is many times you say that investment procedure is done, so now it is healed, so it's okay. But then the best thing is that you take hold of a second wire and you do a parallel wire technique. And now that you've got that thing sorted out and you know this is not going to work out, and then you try and go in. And once you're in and you start hitting some septals or some diagonals, etc., then you sort of feel that yes, you are in the true lumen, and then you keep on going through. So I remember in that one, I finally had to take up a miracle 6 to do the parallel wire. And of course, that is not something which is always recommended, but then that is something that you always fight for.
Time
Here
is
we
short,
go.
so go ahead, please
Hasan
start.
Sohail, please.
Assalamu alaikum, good morning to all. I'll be presenting this interesting case of a 65 years old lady who was pre-diabetic and had been treated previously for CA colon. She underwent an angiogram at an outside facility for CCS2 and NYHA2 symptoms, which revealed a single vessel coronary artery disease involving the ostial LAD, which was severe, osteoproximal LAD, and a moderate to severe lesion in the mid LAD. Her ejection fraction on echocardiogram was normal without any significant
Dr. Sohail,
valvular-
just a second, please. I think we've got a problem. The display over here, and that is not working properly. Can you have the over there?
Maria, can you ask somebody to change the display on this screen also? This screen is different display than that one.
Maybe still the old case is presenting over there.
Okay, you go ahead in the meantime.
Yeah, please go ahead.
The ejection fraction on echocardiogram was normal without any significant valvular abnormality. So in view of persistent symptoms, we decided to go ahead with PCI. These are the pilot shots from an EBU 3.5 guiding catheter. The caudal view here shows a tortuous circumflex system without any significant disease, while this ostial severe LAD osteoproximal disease is evident, and the cranial view confirms a moderate to severe disease after a good-sized diagonal branch. We wired both the OM and the LAD with workhorse PMW wires and decided to pre-dilate the lesion with a non-compliant 3.5/12 balloon up to 14 ATMs. Our plan was to stent from left main to LAD with two overlapping stents. We decided to play, the overlap was planned just after the origin of the diagonal branch. We decided to stent with a 275/26 drug eluting stent at 12 ATM in the mid LAD. There was, however, significant plaque shift, which pinched the good-sized diagonal branch. So we wired the diagonal branch.
Although it's like strange, go back one picture. If you look at that diagonal ostium was, go back one more, diagonal ostium was clear of any significant disease. It didn't seem there was much disease at the LAD where the diagonal was coming. But after, I don't know, there was dissection or something happened probably that resulted in shifting a plaque, the flap into, yeah, it's here now. So flap into the diagonal branch, resulting in that kind of a severe compromise to the diagonal. And after putting the stent, when we saw that osteal thing, I was concerned that there's a large diagonal branch and, okay, go ahead.
So let's let him give the chance. Ji, beta.
So now the question was whether we go for a two-stent strategy here, considering such a large diagonal branch and the only diagonal, sizable diagonal coming off, supplying the anterolateral area, or whether to keep it provisional. We decided to keep it provisional using the modified gel balloon technique. A 2O10 balloon at 10 ATMs was inflated simultaneously with a 3-5-30 regulating stent from the ostium of the LAD overlapping the previously placed modality stent. There was, however, a problem with our inflation device as well in this case. As we were trying to inflate, the inflation device dial didn't go up, but the fluoroscopic images showed good balloon dilation. We were stuck at around 4 ATMs initially, and then suddenly the dial jumped up to about 12 ATMs, the pressure at which we were intending to deploy the stent. So we gave a small puff just to make sure everything was okay, but lo and behold, we had a perforation there.
So I think let's stop here. So what should we do?
You see over here, it is quite clear that the perforation is coming from the point of junction.
Yeah.
And when you have these points of junctions, you try and, of course, put a balloon over here and you seal up this vessel. And once you have sealed up the vessel at a good pressure, then you give a small dye and make sure that you have actually sealed it. Because many a times, actually, when you take up your balloons, you are not sealing the whole place. And once you have got it sealed, then you, of course, wait out your time. Now, of course, the simplest technique over here would be to come back with a covered stent, place it over there, and sacrifice the diagonal.
That's a good size diagonal I didn't want.
But when you are talking of this good size diagonal, the question is you need to have a good size living human being and sacrifice the diagonal.
The patient was luckily stable, so.
Right. So let's see what you did.
So we started off with the balloon tamponade, the 3-5-12 non-compliant balloon on the table was taken immediately. We balloon tamponaded intermittently for around 30 minutes. The results were not very different. We took another balloon, a bigger balloon, a 375 non-compliant balloon with 15 millimeter length, balloon tamponaded for another 30 minutes, and this is what we got.
You see, when we do a balloon tamponade for 30 minutes,
No, not
Intermittently.
not continuously, yeah, like 10,
so
15 minutes.
it is at such moments that I am reminded by my seniors that there used to be a balloon which is called the
Yeah, I have used that, the perfusion balloon.
Perfusion balloon.
We used to have one.
And these perfusion balloons, I don't think
No, it doesn't
no
exist
longer
anymore.
exist.
No.
So that is something that I think that one can always request the industry to sort of
I know, but the
rethink.
reason is that people used to think that although it is called perfusion balloon, but the perfusion really going through that balloon is so small that it's not significant, and that's why they abandoned it, and they don't even make it anymore. So, but which one? Triumph. Okay. Perfusion balloon. Oh, okay. It's available in Pakistan? Oh, yeah. Okay.
Right.
Good. Okay. Good.
And then
So we had repeated echocardiograms on the table. Luckily, there was only trace effusion. The patient was hemodynamically okay. There was no chest pain. He was being maintained on IV nitrates. And since there was no further extravasation, we decided to post-dilate the left main portion of the stent with a 408 non-compliant balloon up to 20 ATMs and remove the wires, shifted. This is the result after post-dilation of the left main, and tried to keep it conservative since the hemodynamics were okay. There was we shifted the patient to the CCU, and we were doing hourly echo monitoring. 4 hours post the procedure, she developed moderate effusion with signs of tamponade. There was early diastolic collapse. There was significant variation at the mitral inflow. So we had to shift her back to the CathLab. We did a pericardiocentesis on her. The pigtail is evident in the pericardial cavity. The relook angiogram, however, wasn't very different from the initial incident that had happened. And there was some trickle of flow which was going into the diagonal now. So we decided not to intervene again at this point, and we shifted her back. The pigtail was there for about 24 hours, and after making sure there was no reaccumulation, she remained stable. We removed the pigtail and drained and discharged her the next day. She's in a regular follow-up and doing well.
MashaAllah. And when you were doing the case, did you do an echocardiogram when you had that perforation?
Yes, we were doing repeated echocardiograms on the table. While we were doing balloon tamponade, the echocardiography team was there.
What I mean is that once you had everything secured and you were about to shift the patient, you did an echocardiogram.
Yes, we did an
You must have had some rim over there at that moment.
Sorry?
Did you have a rim over there? A rim of...
Yes, we had trace pericardial effusion which was there. We had her on the table for over an hour. And we were repeatedly doing, every 10-15 minutes, we were doing echocardiograms. And there was no increase. She was hemodynamically stable. So we...
Perfect.
One issue is that when there is a perforation, usually people think about the reversal of anticoagulation. Where your hardware is there inside and the coronaries, so it's not recommended to reverse the anticoagulation with a protamine sulfate, because it's going to make the situation worse. You will have thrombosis on the top of pericardial effusion. So nowadays it is out of question, because yesterday somebody was discussing about the use of protamine sulfate in this case. When your hardware is out, then one important question is that after using, because we don't have any data, if you use a cover stent or multi-layer stent, should we go for this clopidogrel, or we should go for ticagrelor?
So would you like to take on this question?
I think it all depends on the personal choice. Well, I think clopidogrel probably will be a better choice.
Fine, because we have to prevent ISR, not the stent thrombosis. So I don't think, in my opinion, it would not be any difference in this.
Like in the first case of the Dr. Jabbar, I think it's after 2 months, so it was fully occluded. 1.5 months, there was stent thrombosis inside this cover stent.
Thank you, Dr. Saab. I think we have got another 10 minutes and then we have got a Punjab Institute of Cardiology's case coming. Thank you. Well done. So far, these are the two perforations that you have seen. This is a different kind of a flavor. I'm sure that you will enjoy this one. You see, no matter whichever perforations, whatever you have, no solution is ever the best one. You always want to have something better and better. The concept of putting in, trying to get the body fat out, pushing that in, your coils not staying in the right place. So all of these things are tried. But of course, the good part of both of these cases are that, they went home finally. And I remember one of my perforations long time back, and that was actually because I could not cross my stent, and there's a bit of yanking on that point. And this was again a CTO case that was done. And once that CTO case had been done, I, for economic reasons, decided to keep my wire inside, right? And when you're doing those yankings, you're pushing your stents in, etc., you're trying to create, you at times lose sight of the distal wire, the tip. And this was, though, not exactly a very bad wire to the Pilot 50, but this Pilot 50 did manage to cross a micro channel, right? And I completed my case, I was happy, everything honky-donkey good, no problem. And you are always focusing only on your basic areas. You're not really focusing on all the other areas. So that was a basic lesson to be learned, that once you have completed your case, always look at the distal most part. And then another experience that has come in is that many times when your patients are complaining of slight discomfort, it's many times not because of what you're doing over there, it's because your wire has traveled into a small vessel, and that is causing the pain. Okay, so Dr. Rana Mohammad Tayyib from Punjab Institute of Cardiology, one of our good senior registrars over there, please.
I think we can go ahead just without discussion because your time is short. So.
But I think this is a short case.
Yeah, that's good.
This is a case of primary angioplasty.
Okay, great.
Right.
जी डॉक्टर साहब.
So a middle-aged, 50 years male, hypertensive smoker presented to our emergency department at 12 night with the history of chest pain for 6 hours. So ECG was done and short echo was performed. So ST elevation from V1 to V6 and short echo shows moderately severe LV systolic dysfunction with the hypokinesia of LAD territory, but blood pressure was 140/90, heart rate is 92, and saturation was 96%. So the initial ACS protocol was given, consent was taken, and patient straightforward shifted to primary CathLab. So here is the angiogram, right coronary artery that is non-dominant and normal. So, left system, LCX is dominant, normal, and there is a huge aneurysm at osteoproximal of the LAD. So there are a diagonal branch which shows also normal, and a little branch shows the evidence of clot. So here shows the mechanism of acute MI, that is the thrombus in the aneurysm of proximal LAD. So question is open, how we will do next? Yes, this is the view of iliocranial. So how to proceed?
So what's your opinion? Do you what next step do you like to do? Your opinion.
Sorry, you were asking, I'm sorry, I was asleep. I'm not an influencer these days, but I think, LAD is obviously at the junction of LM and LAD, there is a bit of dilatation, which seems to be a kind of dissection of some sort or aneurysm of some sort.
Dr. Langriyar, your plans for the next step, apart from playing with the mobile?
Could it be a dissection also? That's what I was thinking about, because
You think this is a dissection over
maybe,
here?
yes.
Maybe. Okay, let's see what happens next. You are privy to the case. You are privy to the case.
But it's a very challenging. You see, then this is a difficult one.
Yeah.
Okay, let's see what you did and what was the point.
So there was no channel to LAD, there was no retrograde filling from left or right system, huge aneurysm. So as it was acute MI patient, so routine workhorse wire BMW was taken, of which IUS could not cross the lesion with the help of the balloon. Even then I took the whisper wire, which negotiate into the channel, and with the help of the balloon, I was able to negotiate the wire distal into LAD.
And when you had the wire in, was the flow established? Because many times in acute cases, the wire, just taking the wire in makes the flow come back.
Yes, so after ballooning at the lesion with the 2 × 15 at nominal pressures, so what we see next?
So this is the establishment of the flow.
Yes, flow was established. It's TIMI 1 to 2 flow with the huge clot burden. So against to the panel, what's the next plan?
इधर प्ले रखो बेटा इमेज को क्या नहीं माइनस करना. So what would be your next line of action over here? zeros up at the end.
Now this is acute MI. There is clot over there. You have opened a vessel now. Although it's very difficult to deploy any fully opposed stent here because it's an aneurysm there. One option is to do the IVUS to see what actually it is, what's the size of this, how you can deploy a stent there. Again, in acute MI, it is very difficult to go for IVUS theoretically, but in acute MI, we can give, agrastat and then deploy a stent there. Try to put it in the neck so that we can just deploy it. It should not be hanging in the aneurysm.
Next.
Rather than anything else, but deploying a stent would be the last.
Yeah, I agree with you because that's midnight and it's a primary PCI case. You have opened up the vessel now. The best thing would be to dilate it again and then see the flow, and if it's fair enough, then you can leave it.
So we did the thrombus aspiration with, and this much of thrombus was brought, aspirated. Intracoronary agrastat was given and infusion was started. So this was the flow. Again, there is a huge clot burden. But at night in the primary CathLab, I have the maximum size of the stent was 4.0 and the balloon was 4.5 or 5 maximum. Here the size of the vessel is about 8 to 10 and the aneurysmal size is about 14. So what to do? Which stent?
We should leave this case, give him agrastat for 48 hours and call back this patient after 48 or 3 days and re-see the, because you have already established TIMI2 or 3 flow.
For the question over here is that everyone is sort of was quite clear that of course you are not going to do any further intervention. The point to be reviewed is that what is your choice? Do you want to stick with the 2B3 inhibitor or do you want to go a full-blown anticoagulation, keeping his APTT levels at 3 and then from there moving forward? So what is your take on it? What is your choice for such a patient? Sir.
Yes, I completely agree. See, the problem is there's an aneurysm, the aneurysm formed a clot, and that decided to go distal and occlude the artery. There is no atherosclerosis in these arteries. So again, stenting is out of question. And agrastat, well, it's a fully formed clot, and the platelets are trapped deep inside. So I don't think agrastat is really going to be meaningful here. Cases like this would be one rare case where you would want to give intracoronary TPA and maybe give it several times and you can establish flow. This is a patient who needs to be on lifelong or persistent anticoagulation. I don't think it's a platelet.
I understand. Dr. Tayyib has a point.
Intracoronary TPA, just 2 milligrams would do wonders here, and you can just puncture your balloon, give it through that, or use the same thrombustor and give the ICTPA, and then just leave him on agrastat. You can give him anticoagulation with heparin, but I think agrastat would be a better choice, as the consensus is stenting is out of question. In RCA, they have documented case reports of deploying peripheral stents that can go through a 7 French guide system, like a self-expanding stent. But I'm not aware of anything to be done in the LAD. But RCA, yes, they have shown like a 6 millimeter or a 7 millimeter self-expanding stent to be deployed in the RCA.
Yeah, but I would be very reluctant to put a stent in.
No, not at all. This is out of question. This is
one more point that was just before we kind of start showing you what we finally did. One thing was to be asked was that how many of you would consider, if you have the inventory, of course this is the question of inventory, how many of you would consider having a higher French go in and a peripheral thrombectomy device coming in? How many of you would consider, if you have the inventory?
angiogen.
Perfect. And so, okay, let's see what you did finally.
Yeah, just wrap it up, please. We have to start the next session. Everyone is waiting.
So, please, 15 minutes late start.
Sorry, that's we have to
So-
finish our time.
Okay.
Patient was put on agrastat for 48 hours as sir advised, and dual antiplatelet therapy, anticoagulation. So patient was pain-free, no hemodynamically stable, so shifted to the CCU, and after 4 days we did the check injection, and what we got now. Totally occluded, again LED with evidence of thrombus there.
Is ST settled or they went up again or no?
STs were not settled, it was about 1 to 2 millimeter elevated.
ST is never settled even after the first.
50% resolution, like
No, they don't.
very good flow.
Let's keep going.
At
please.
that
We have
time,
to finish.
we had STs, settled STs to about 50%, and patient was pain-free and hemodynamically stable when we shifted the patient to CCU.
Please go ahead. Just finish it quickly. We have to start the session.
Okay. So we referred this patient for cardiac surgery.
Yeah, I wouldn't have referred for surgery after that long. It's probably dead already, infarcted tissue. So I don't know. This is my personal thing, but I would be very reluctant. This has been closed for more than 24 hours. I would definitely document viability or something before I would consider that. But anyway,
Obviously,
I think
work has
we
been-
have to stop, unfortunately. I'm sorry.
You're perfectly right. That's the whole plan, is that we will be doing our viability studies, and then if more than 5 by 10 viable, then we'll be pushing in for a cabbage, so that whatever we can be salvaged, it can be salvaged. Thank you for this breakfast session, and hope we have a great learning. Today, from Punjab Institute of Cardiology, after about another hour or so, you'll have intermittent 3 hours of live telecast coming from our center. I hope you enjoyed. There are a lot of challenging cases coming on for your good vision and analysis. Thank you.
Thank you very much, Dr. Bilal and the panelists. Good session. So we're going to move on, start our regular sessions. Our first session is going to be moderated by Dr. Howard Kazmi. I would request him to come up here and start the session, please. Okay, so this is a very interesting session. Next one, it's basically hot debates, and I think this is a new thing which we started this year in Pakistan Live. And actually, I must thank Hakeem, who suggested that we should have these debates this year. So it's really going to be very good, and we were lucky enough to have international speakers in these debates, so I think it's going to be very, very interesting. So I think our moderator is going to be Dr. Howard Kazmi. We have excellent panel of experts on virtually on Zoom as well as physically. So virtually, I'm not sure who, okay, so we have almost all of them. Dr. Rosalie, thank you very much for coming. Good morning. So I think he doesn't need any introduction. Everyone knows him very well. Then we have Dr. Bilal Murad. Thank you again. You have been up all night, I know that, for the last session, and you are now again too. Thank you. Everyone knows Bilal as well. And Dr. Tan Hui Chim, he's the past president of Asia Pacific Society of Interventional Cardiology. Dr. Ashok was there yesterday, who is the current president. I'm very grateful, Dr. Chim, for you to be here today. I know you had a very busy schedule, but you were able to spare time to be here. Thank you so much. Then we have Dr. Mirvat Alesnag
from Saudi Arabia. I think most of you know her very well. She's active, very active. I think in all the meetings you see her everywhere in Sky and Europe PCR and everywhere. She's an excellent interventional cardiologist from Saudi Arabia. We have Dr. Najib Azam from UK. I think most of us know him as well. He's a great interventional cardiologist. Dr. Sydney Lowe, I don't know if he's here or not. Yes, so he's there. Thank you, Dr. Sydney. It's great to have you here. I know last time you couldn't make it, but this time he's there and he's going to give us a talk also. He's from Australia, again part of Asia Pacific Society of Interventional Cardiology and a great interventionalist from there. And who else? Dr. Rizwan Khalid is again from USA. He will be giving a talk, a great interventional cardiologist. He was a past president of APNA as well. So I think Dr. Mubashir Mumtaz is there. I don't know who else is. So I think these are all the panelists from on Zoom. And we have panelists from here, Dr. Zubair Akram, Harun Babar, Khurram Shahzad, Hamid Saeed, Dr. Saulat Fatmi, Dr. Mansoor Ahmad, and Dr. Ghulam Hussain Somro. I think whoever is here, they can come up there. Dr. Ijaz Ahmad, if you could come up, please. Dr. Mansoor. Dr. Shahbaz, if you could please come up there as well. And Tayyib, Dr. Tayyib Mohyuddin. And Dr. Shahzeb. Okay, Dr. Howard, please come up. You can take it from here.